Welcome to the Life's Best Medicine podcast, where we are finding hope and healing one episode at a time. No appointment needed, no rubber gloves, and no copay. Just a healthy dose of life lessons to help equip you for this wild journey we call life. Hey everyone, this is a friendly reminder that we are here for entertainment purposes only. We may not even be that entertaining at times, but this is not medical advice. Talk to your doctor, check with your healthcare professionals before making any lifestyle changes or medicine changes. What we're talking about is our clinical experience and what we've seen. And so if you really want our advice, you can consult us. You can actually consult me as a doctor, or you can consult my guest and get all your questions answered. But we can't give free medical advice because we can't pay our bills with that. But we can help to educate you a bit and allow you to think a little bit. And always reach out to your medical professional before making any lifestyle changes. Thank you.
Discover a new path to wellness at Arizona Metabolic Health. Dr. Brian Lenskis offers advanced medicine and personalized care, treating the root causes of your health concerns, not just the symptoms. Whether you're seeking direct primary care, effective diabetes management, or medical weight loss, with a holistic approach, our team is here to guide you every step of the way. Visit ArizonaMetabolicHealth.com today to learn more about our innovative health solutions.
Hey everyone, welcome to 2026. Can you believe it's here already? I'm losing my voice, but besides that, it's going great. And just want to give a shout out to Health Code, Get Health, GETHLTH.com. Great protein shakes, vanilla and chocolate macadamia. Both are awesome. Great way to reset for the new year. A lot of us may have had some cookies and cakes and different things during the holidays. Now it's time to get back and reset that metabolic clock here. So reach out to Health Code. They're doing some great work. They've been a great sponsor for me. They have berberine there that helps with insulin sensitivity. They're coming out with some new products that I'm really excited about. They have some flavorings. You can go on their website and check them all out, see what flavors you like, that you could add to your vanilla or chocolate to spice it up a little bit so you're not having the same thing all the time. So Happy New Year. Health Code, thank you for all you're doing. And I'm really excited about some of your new products that are coming out. So everyone, please support them. They've been a great support to me. Thank you very much. And happy 2026, everyone. Hello, and welcome back to the Life's Best Medicine podcast. Today, Dr. Peter McCullough, one of the most published doctors, cardiologist, huge leader throughout the last few years. I mean, he was a gold standard going way back. He doesn't need an introduction. I don't want to waste time on that. But Doc, welcome. Thanks. It's so great to have you back. We had you on in August of 23. You hold the record of the shortest time this podcast was taken down, 17 seconds by YouTube for medical misinformation.
Oh,
and
my Lord.
We can go back and listen. It will be everything we talked about was factually correct. So at that time we were talking about treating COVID, risk factors, diabetes, obesity, all those kind of things. And now we're in the dilemma of treating the vax injured. And I would love to, I know you've been on the forefront of this, so I'd love to hear your take on what we're seeing clinically and what we can do to help people.
There are several survey estimates, and as an internist and cardiologist here in Dallas, Texas, I'm following the literature closely. I'm president of the McCullough Foundation, chief scientific officer of the Wellness Company. And I can tell you, Brian, that the best estimates are of those who took the vaccine. I think it's somewhere between 5 and 10% have some medical problem from the COVID-19 vaccine. And so from the very early, immediate cell phone survey data that the CDC had, there's 10,000 Americans who participated in that, it was 7.7% who really got in trouble. They went to ERs or clinics, what have you. And then there's been a Zogby survey and a whole variety of other surveys, Rasmussen. So I think it's about 5 to 10%. Recently, former CDC Director Redfield, who actually is in clinical practice, he thinks it's about 15% of his clinical practice is those injured by the vaccine. I'd say in my practice, which is more of a national referral center, it's probably more than half have some problem after the vaccine. And In my view, it's related to the spike protein. The spike protein is the spine on the surface of the virus. It's when we get the infection, we just get the tip of the spike protein, the S1 segment stuck in the human body. It becomes incorporated inside of cells, monocytes, and it can be there for a year and a half or longer, just after the infection. Everything I know about it is the spike protein is the cause of long COVID, and that the inflammation and everything else that occurs is in response to the spike protein, but it's the cause of long COVID. Now, when we enter the vaccines, Pfizer, Moderna, they make the full-length spike protein in the pre-fusion conformation. So it doesn't interact with the ACE2 receptor at all. It's actually pre-fusion. It doesn't fuse with the ACE receptor, so it doesn't have any receptor-mediated catabolism. And we have free spike protein that quickly wraps into threes called trimers, and that's found in the bloodstream of the vaccinated. The full-length spike protein, 1,200 amino acids, about a dozen glycosylated side chains, and this protein, devised in a Chinese biosecurity lab, is indestructible, as far as we can tell, from human enzymes. There's not a single study showing a naturally occurring human enzyme breaks it down.
Yeah, and the scary part is what I'm seeing now, people 4 years out, 5 years out now, 2021, they had their shots and their spike protein antibodies are still above 25,000. And, and I have 3 patients in my practice who are going into their kidney function is progressively worsening with no other explanation, no hypertension, no diabetes, no meds, no NSAIDs that can be causing that. And when I checked, all of their spike proteins were above 25,000. And when you start seeing that, you don't even know how high it is. You just know like that's the max that we have on our test.
Right. So we've talked to the assay you're talking about it's actually a binding unit assay offered by Roche Alexis through LabCorp, which reports out a range up to 25,000 units per ml. LabCorp says they can even report higher if they would do it, 50,000, 100,000. Quest, the other major lab company, they truncate it at 2,500. Now, remember, it's just an antibody to the antigen, so it's an indirect measure. There's not a single commercial laboratory in the world that has a regulatory approved spike protein antigen that we can measure in the blood. And remember, it's just a protein. We measure the TSH, we measure albumin and globulin. Those are just proteins. They're easy to measure by a method called ELISA, enzyme-linked immunoassay absorbent assay. So it's very easy to do. And I can tell you, if I was FDA commissioner, our current FDA commissioner is a surgeon, Dr. Marty Macri from Johns Hopkins. If I was him, I would have fast-tracked a spike protein antigen test. And I'm sure the lab companies would love to offer it because that's revenue for them. It's an easy test.
Sure.
To make it available to you and I as clinicians as we're trying to take care of patients. But when I inquire about this, well, why isn't there a test anywhere in the world? The answer is the regulatory agencies refuse to fast track or approve a spike antigen test for the bloodstream.
Wow, that's scary in itself because like you're saying, if we can't break it down, the point is, people listening, if we get the flu, if I check your antibodies to the flu virus, right, when you have the flu, it goes really high. And then a month later, 2 months later, it's going to be negligible, right? Because that's not the mechanism. You don't just keep making antibodies unless the offender's there. So why do we have good data on why we're seeing this, why we're seeing these antibodies still elevated, 5 years after the fact?
Well, let's take the infection first. So the tip of the spike protein can stimulate antibody production. In a comparative paper by Barham and colleagues who examined patients with long COVID and those with vaccine injury syndrome and compared them, they found that the average long COVID patient had spike antibody levels around 2,000 or so, 2,000 units per ml. And those who took the vaccine and had a problem, 11,000 units on average. Now, we're working with a laboratory called Inmodia, and they are about an hour outside Munich, Germany. And what they've indicated, and multiple specimens indicate this, is when the spike antibody levels are over 5,000, which sounds like you have several in your clinic, for sure there's going to be full-length vaccine spike protein circulating in the human body. When it's under 5,000, so far we haven't found any cases where there's any more spike left in the bloodstream. It's just residual antibody production. And among the peer-reviewed published studies on prognosis and antibody measurement, there, when you're below 1,000, there's no signal of any danger whatsoever. So what we're trying to achieve is a spike protein antibody level less than 1,000 over time, giving it plenty of time. And the inference is the spike protein is out of the body. Now, our National Institutes of Health, led by Dr. Jay Bhattacharya, has not initiated a single study of the vaccine spike protein. Not a single one. Now, remember, he's been in power for a year. And if I had his position, I would have had a full research, bevy of studies in academic laboratories measuring patients like yours and mine who have very elevated antibodies and seeing what the spike protein level is in the body and where it's in the body. And when examined, the spike protein is found in all the tissues of the body. It's been found in the heart, the other vital organs, been found in the blood vessels of the brain in patients who've had aneurysmal rupture. Recently, in a patient of mine, we found it out in his skin. It was causing a skin rash called Grover's disease. Grover's disease. And so the great concern here, Brian, is we've all been poisoned. We've been poisoned by this foreign protein that came out of a Chinese biosecurity lab, and the poisoning occurred via the mechanism of the infection, and it's even far worse after taking a COVID vaccine.
Yeah, I always wondered that. I'm wondering why the nucleocapsid is not changing as much as the spike proteins. I'm wondering why they at least they didn't try to go after the nucleocapsid. Yeah. Do you have any like studies that you've seen on that of why they went after the spike protein, which is the most toxic part of the virus?
Well, the early studies, the in vitro studies, said if you took a virus and you exposed it to an antibody that blocked the binding site of the spike protein, it completely neutralized the virus. I mean, it looked like a brilliant idea. Just, have an antibody that neutralizes that receptor binding domain. Nucleocapsid didn't look so good, although nucleocapsid offers about 30 proteins in the nucleocapsid. The spike is just a single spike protein. Oh, remember, by the way, when we do a PCR test to diagnose SARS-CoV-2 infection, there's 4 primers. Several of the primers are actually nucleocapsid protein, the N protein and what's called the E protein, the envelope protein. But here we go. The target was the receptor binding domain. The vaccines roll out. What's the first thing the virus does? It mutates the receptor binding domain. So the vaccine is useless in terms of raising antibodies against it. And so the antibodies are a proxy for the vaccine spike protein, but the antibodies confer no protection against COVID at all because the spike protein is already mutated. So the FDA learned that quickly. And on their website, I think in 2021, it has a strong warning: do not use the antibodies to try to confer protection against SARS-CoV-2. And they were specifically talking to the vaccinated who thought they were going to be protected by the vaccine.
Well, I think that's a huge issue people don't understand also is you can't predict what's coming. So they're saying get your updated shot so that you can fight off the new variants that are coming. So, well, isn't that based on the previous variant that we've already seen? By the time we get the virus, it's already obsolete, right?
Well, completely obsolete. I mean, that's the thing with SARS-CoV-2. So every time a booster rolls out, the variant that it's keyed against is completely gone. And there's a hope, well, maybe there's enough homology with the remaining epitope to have some efficacy. But an annual booster strategy is a flawed strategy for a couple reasons. One, all experts agree any theoretical vaccine protection only lasts a few months. So you're taking an annual shot for, 2 months of potential benefit? That doesn't make any sense. If you really want full benefit, if this is really to prevent COVID, it would have to be a shot, at least every 6 months, maybe every 3 months. And then the other thing is the fact that, there's no consideration over whether or not someone's already had SARS-CoV-2 infection. And there's a big several big serologic studies, one at UT Houston here in Texas, where 97% of us, Brian, have already had SARS-CoV-2 infection. In my clinic, I've identified a handful, probably less than 5, that have no antibodies to nucleocapsid, meaning they don't have any evidence of prior infection, but it's very rare.
It's extremely rare. And what's interesting to me, and this is what really started me looking at this, is I have 3 women who came to me with a diagnosis of long COVID. When I checked their nucleocapsid antibodies, negative in 2 out of 3, which is surprising that anyone's negative. Like you're saying, 97% of us already have immunity to it.
Right.
And it's like, what's the odd? And so they were all 3 vaccinated, but 2 out of the 3 never even had COVID.
Well, yeah. One of our cases that we're writing up right now, where the claim is, I think he's at now 3.6 years after taking the shot. He never had COVID. So this is a perfect case. So his nucleocapsid is negative, and his spike antibodies initially were over 5,000. He clearly had spike from Pfizer in his bloodstream in trimers, full-length spike. He had spike fragments, it's important. He had fully measurable Pfizer messenger RNA in his bloodstream circulating. And then he had all kinds of DNA fragments. So remember, Pfizer and Moderna are made from a plasmid system within E. coli. And the plasmid contains the DNA code for Pfizer and Moderna, but also some accelerators called SV40, the promoter, the enhancer, the inhibitor, antibiotic resistance genes. And what the German lab has been found, the Emodia lab, is that there are DNA fragments for the messenger RNA, so some fragments coding for spike protein. There are fragments coding for simian virus 40, the promoter, the enhancer, inhibitor, and antibiotic resistance genes. And so there's essentially a genetic soup that is in each Pfizer and Moderna vial. And the concern about DNA is that it's readily taken up into cells. And what we don't know is how much of that is directly incorporated into the human genome. Now, a recent paper by Cantazzaro and colleagues that's fully peer-reviewed, and it's in the National Library of Medicine. I mean, this is as good a science as you're going to get. In our patients that we're studying, found that roughly 20 base pairs of code for spike protein is in the human genome. We found this in a cancerous cell of someone who took the vaccine. Not the entire 1,200 base pair code, but 20 base pairs. So this is kind of a mixed finding. It's not full human genome integration, but it is some foreign integration of either a fragment of DNA that was in the vial or a fragment of reversed transcribed messenger RNA that's occurring in the cytosol of cells.
Yeah, and it's so scary. And again, clinically, these are the things you think, how can I still be making this spike protein? The concern I have, and this is why I wanted to have you on, particularly for this issue, because I know you have the ultimate spike detox. Mm-hmm. I would love to talk about and I have no financial interest, by the way, anyone listening, but I'm using it because it's helping my patients. I'm seeing clinical improvement, which makes me happy. And I know there's some people who have very advanced and they may not touch it possibly, but mm-hmm. with what we have now, what are our options now to treat? Because my concern is this: okay, if it is the DNA and we are continuing to make the spike protein, we're cleaning the river, and the factory keeps polluting the river. At what point do we think this factory is either going to shut down or we're going to make some progress at cleaning the river faster mm-hmm. than it's making the product, right?
So far, considering the Cantazzaro paper, and then there's a prior paper by Alden and colleagues, I don't think the full-length Pfizer or Moderna code is in the human genome. We just don't see evidence of that right now. So we're left with just very long-lasting Pfizer and Moderna that's been fully pseudo-uridinated. It can't be broken down by human mRNAs. The only way the messenger RNA gets out of the body is probably through secretions, to be honest with you. It's been found in sperm. It's been found in breast milk. So if we take the messenger RNA and someone says, "Doctor, how can I get this out of my body?" I said, "Listen, you ought to be sweating like a horse every day. I'd go in a sauna as much as you can. I'd go outside and sweat." I think that's the reason why the athletes, after the initial wave of myocarditis, sudden death, that's the reason why the athletes have done pretty well. I think they sweated this stuff out of themselves, to be honest with you. I really do.
Wow.
Yeah.
Wow. So you don't think that we're continually making the spike protein? We just can't break it down what's there already.
Right. Well, we can't get rid of the messenger RNA, outside of,
Yeah.
remember, detoxification is the liver, the kidneys, and sweat. And right now, it looks like the main mode of exit of messenger RNA is sweat. So I think one of the most popular non-medicinal approaches is people to get these home saunas and sweat like crazy. The patients who have had the greatest drop in spike antibodies have incorporated sauna and sweating into their program. Okay, so it's very important. Now,
and some people are talking about fasting also.
Well, let's
Maybe
go through. Let's go through what works. So the nice thing about artificial intelligence is that it is kind of a DeepSeek synthesis of kind of what works and what doesn't. So sweating and messenger RNA getting out that way, that works. Hyperbaric oxygen, the studies seem like it improves symptoms, but there's no mechanism by which hyperbaric oxygen would help you get rid of messenger RNA of spike. But having said that, there's positive data. The same thing with ozone. People who give extracorporeal ozone, take blood out of the body and try to hyperoxygenate. Again, no mechanistic rationale and no clinical evidence. The same thing with nicotine or low-dose naltrexone or ivermectin or hydroxychloroquine. You're not physically getting rid of messenger RNA and you're not physically getting rid of spike. And there's you can't find a shred of evidence that that's the case. Now we get into the enzymes. Enzymes are very different. You do a standard artificial intelligence search and say, does nattokinase, which is in the ultimate spike detox, this is the ultimate spike, does nattokinase get rid of spike protein? Answer, yes. Yes, multiple sources of evidence. We have published peer-reviewed cases where this works. Does nattokinase get into the bloodstream? Yes, there's been pharmacokinetic studies showing you take it on an empty stomach, you get some of this in the bloodstream. Remember, the human body is pretty good at just getting through things through the GI tract and not letting it get into blood, but natto gets into blood. So nattokinase is on base for sure. How about bromelain, another family of enzymes developed from pineapple? It's in the ultimate spike detox. Answer, yes. Every single system shows yes on that one. Okay, terrific. That's on base. Then there are some other things in ultimate spike detox that are assistive. For instance, curcumin. Curcumin helps block inflammation from the spike protein. Does it get rid of spike protein? No. Black sativa, dandelion extract, Irish sea moss. No, those are assistive, but they are not, in a sense, detoxifants. What about, and that's essentially the enzymes. Now, there's a few more enzymes which the answer will be yes. One of them is papain, and that is in the wellness company Kids Spike Detox. Another one where it's theoretically possible is sereptase, but no clinical data. Here we are 6 years into this, no clinical or laboratory data. And then also lumbrokinase. Again, theoretical, no laboratory clinical data. So in wellness company, we're going with the scientific support in the ultimate spike detox. Now, you brought up N-acetylcysteine. N-acetylcysteine, that's in what's called ultra NAC. N-acetylcysteine exclusively works on disulfide bonds. Turns out in the spike protein, there are some disulfide bonds, not much, but there's a theoretical basis by which N-acetylcysteine may help change the conformation of the spike protein so it doesn't interfere with the ACE2 receptor. So that would matter for people who've had the infection and they have the natural spike. That can interact with the receptor. But remember, a vaccine spike cannot interact with the ACE2 receptor. So N-acetylcysteine, for those who took the vaccine, theoretically would have less of an opportunity to do something. Now, the question is, does it denature the spike protein? No, it doesn't look like that's the case. There is a company in Europe that's making claims without published scientific evidence that a form of N-acetylcysteine can have its nuclear magnetic resonance change. It's called augmented NAC, and that it can denature the spike protein independently, and they have spike fragments come out in the urine. And there's just, there's no mechanistic support for that, and there's no published peer-reviewed data on that. I mean, I love the claim. It would be great if that's the case, But Wellness Company, we created an ultra NAC, and we combined it with some other evidence-based detoxifants. We had to go through the Federal Trade Commission for this and what have you, and they include milk thistle and others. But the bottom line is, N-acetylcysteine, yes, it's in my recommendations for patients, but not as a standalone treatment.
Yeah, just as an anecdote, I was just on a conference call and we started talking about spike protein, and I was like, hesitantly talking to a bunch of doctors and researchers. And one lady actually said, "Hey doc, I'm surprised you're talking about this." And she goes, "Guess what I had?" She told me she got pulmonary emboli, DVTs. She was getting microemboli in her fingertips and she was in severe pain, and she went to 5 doctors. They all blew her off, said, "There's nothing wrong with your blood. We checked it. It's fine." She's like, "Look at my fingertips." Anyway, she went on the augmented NAC, and she said within 5 days, her fingertips stopped hurting. Her shortness of breath started improving, and she took it for 2 months and went off it. And then obviously there's just an anecdote, but I was like, wow, I'm happy to hear that at least, we could do something, because it's such a helpless feeling as a doctor to say, this is new to us. We've never seen this in our, careers, obviously. So trying to figure out, okay, how do we minimize the damage? And I think
remember, Brian, it's important to take an anecdote like that and analyze it. So you'd ask yourself, is there any evidence that she actually reduced spike protein microthrombosis? No. Does N-acetylcysteine influence thrombosis at all? No. And does anything work on spike protein in a few months? No.
All right.
So the point is,
it may just be,
Yeah. So if anything works, it's going to be a year or more. And in our published cases, we have spike protein going from 19,000 down to, below 10,000 or below 5,000. But like in a year, we have spike protein clearing out of the bloodstream, in 9 months or a year. Be wary when there is a single product and that it offers a miracle cure in a very short period of time. It's just, I got to tell you.
It's just the nature of the disease. It takes time to detox, for sure. You're not just going to do it like that.
There's no disease like this. If I told you, wow, I've got a patient with systemic lupus, we're going to give them a couple months of something and they're cured. There's no way. And so, be wary of this. At the Wellness Company, we've got a medical board. We got seasoned doctors. We know, listen, this is a tough disease. Every product we make, by the way, has about 6 to 8 different active ingredients in it. And we use this in addition to prescription drugs. So we use prescription drugs. And we know that these supplements are assistive. But anytime someone says, well, I took nicotine and I was cured in 2 weeks, it's just, it's not believable. I'm glad your patient got better, but boy, is she at risk for?
Yeah, she's not even a patient of mine. She's just a person I talked to, a scientist.
Is she at risk for another pulmonary embolism? You better believe it.
Yeah.
So I haven't seen the risk of pulmonary embolism really go down until we've substantially reduced the spike protein measures. And even then, I'm still greatly concerned about patients. And by the way, with pulmonary embolism, I check everybody for genetic factors for hypercoagulability. And I find in about half of patients, they had a genetic predisposition to blood clotting.
And it's just them over the top, the chronic inflammation.
Remember, there's about 800 to 1,200 determinants of blood clotting in the human body. We can only measure about 7 of them. So people say, well, I don't have an inherited thing. I'll say, well, yeah, we can look at 7, but chances are you do. But I just had a patient email in yesterday. I saw her a long time ago. She just had a massive pulmonary embolism, and she's out of state. And I was looking through her records and no vaccine. So the spike protein itself can cause blood clots from the infection. This is well described, by the way. And the medical orthodoxy refuses to acknowledge the infection. This is very important. They're refusing to acknowledge a broad base of literature. So, for instance, one of my patients did not take the vaccine, but had the infection. About 2 weeks later, had a whopper deep venous thrombosis from the ankle to the hip, Brian. Huge. We never saw this before COVID.
Yeah.
And goes to the Mayo Clinic and says, listen, I think the infection was related to this whopper blood clot. The Mayo Clinic told her, no, it's not due to the infection. We don't know what's causing it, but it's not due to the infection. And we're seeing this all over. Do you know, if you look at Mayo Clinic histories and physicals or Harvard or the rest, they do not note the COVID vaccination status or the COVID history at all. It's as if it didn't exist.
Yeah, I mean, those are things we have to look at as a society to go, look, we have to know like risk factors. I'm relieved when I hear someone who's not vaccinated now when they come to my practice and go,
Right.
gosh, decreased risk of a lot of stuff. But I think there's just such a concern. And this is new
But
to me.
Brian, think about this. Remember, at the major academic medical centers, there's no historical importance put at all on the COVID vaccine or on the COVID illness for anything, despite thousands of papers. Do you know Primed, the big primary care CME series? Nothing on spike protein at all. You look at any CME offering anywhere online, nothing on the spike protein. American Heart Association, American College of Cardiology, nothing.
Why do you think that is, Doc?
Because I think there is a willful blindness to the pandemic and the spike protein. Because if there was any investigation into this, people would realize, wait a minute, this infection is related to a lot of bad things that's happened to us. It was completely mismanaged as people were allowed to get very, very sick and become hospitalized because they did not treat patients with McCullough protocol or other protocols. And on top of that, to make things worse, the medical community fully embraced the vaccine, which fully loaded more spike protein into individuals worldwide. So the entire world has been poisoned by spike protein. The medical community has turned a complete blind eye to this and is wishing it would go away.
It's not only a blind eye, Doc. There's like personal attacks, and when I say here's what I'm seeing clinically with these huge spike, a
Right.
lot of doctors, no one's talking about it. There's a few people out there, a couple of people going, yeah, I'm seeing the same thing. But it's so rare. No one's checking. No one's saying, hey, this is odd, because I'm seeing an odd constellation of symptoms with migraines and feeling fatigued and brain
Mm-hmm.
fog and all this stuff. And I'm like, let's just check it. What the heck? And then when I start getting the numbers back, I'm like, I almost didn't want to know because it's so devastating.
Well, it's gotten to a point where clinicians like you and I realize this, and patients want the spike antibody level, that LabCorp recently has opened this up to the public. So if you go to labcorp.com, go to Labs on Demand, click COVID antibody test, pay $69, enter in your name and email stuff, you could just go to LabCorp and get your own spike antibody level measured. And so LabCorp has essentially broken through where the medical community, because I can tell you, Mayo Clinic categorically refuses to order a spike protein antibody level.
A
Now,
lot of big organizations refuse. Absolutely. They won't check D-dimers. They blocked a lot of it's just incredible.
Well, think about this. Now, they'll measure antibodies against the Lyme disease organism, Borrelia burgdorferi. They'll measure antibodies against cytomegalovirus or antibodies against Epstein-Barr. But no, they will not measure antibodies against SARS-CoV-2 spike protein. I mean, that should tell you right there that we've got a problem. And Americans are scrambling to doctors like you and me and others, and there's relatively few of us. People are getting their own spike protein levels. I've done a series of advertorials and educational sessions on this to say, listen, if your spike antibody levels are less than 1,000, I don't see any signal of worry out there. And in fact, if a new problem develops, I'm pretty sure it's not related to anything related to SARS-CoV-2 or the vaccine, right? So I think it's very useful if if the spike antibody levels are 1,000 to 5,000, it can cause some mild symptoms. That happened to me, by the way, Brian. Mine was about 2,300. I had COVID a few times. I had COVID more severe in 2020, and I had to go on spike detox. My ears were ringing. I didn't feel well. I had bad tinnitus. And it took easily 9 months of full detox. I did the full detox. I did it with our original product and then this. And in about 9 months, I noticed really a noticeable change in the tinnitus. It went down. It's probably now about 10% of what it was. I can actually hear you in the earpiece. Before, it was just so loud. And now my spike antibody levels measured probably about 6 months ago were 900. So I've gone from 2,300 down below 1,000. Terrific. I probably never had spike protein in my bloodstream, but I probably had enough of it in my, my auditory nerve and the other neural tissues to bother me.
So clinically, if someone's less than 1,000, we don't have to worry about it. Over 1,000, treat.
Right, over 1,000, treat. Over 5,000 is probably in the bloodstream. And then I personally have found it to be pretty rare for someone to be over 25,000 without a problem. And if they don't have a problem, now it's going to happen. So I had a nice doctor in my office yesterday. It's really good. He's a pathologist. He's very assiduous. So he's done 2 baseline spike antibody measurements before detox. And he has a classic vaccine neuropathy. It's been, he's had EMG testing, nerve conduction. I mean, this is a solid diagnosis. Been to Mayo Clinic. And he has his 2 measurements self-ordered, and he's right at about between 8,000 and 9,000. And I said, boy, you're a perfect case, because now we're going to start detox, and we're going to see those antibody levels drop. And so we want to see about a 20% drop. So the reason why 20% is important is that it's more than statistical variation in an antibody concentration. So there we know the antigen is moving in the right direction. And we tell people, listen, you can't get COVID again. Getting COVID again is going to reboost these antibody in the spike exposure. So we put people on nasal sprays and gargles to reduce the SARS-CoV-2 exposure, and twice a day, every day. And then we'll recheck him in about 9 to 12 months. Well, he's a doctor, and his wife was with him. Now, they both took the vaccine. And she goes, doctor, I'm at over 25,000. So it's interesting. He's at 8,500. Now, they didn't take it at the same time out of the same vial, but she's over 25,000. So each person is different, either in the response in making antibodies or in the messenger RNA concentration in the vial. And that's another issue, is that not every vial is the same. The lots are different. That's been well established in multiple databases. Yeah. Not a single government, including ours, and Dr. Marty Makary is in charge of this, he refuses to issue a examination of the vials for messenger RNA concentration.
It's absolutely mind-blowing, especially knowing what we know now. It's like we're speculating. It's not theoretical anymore. No. We have data. We're doing the testing. We're seeing it, and no one seems interested. That's what's amazing. And I get what you're saying. A lot of doctors force this on patients. They're bonus dependent on this, and they didn't discuss risk and benefit. Now all of a sudden they're in a weird position where they're like, oh my gosh, I don't want to know if it caused damage. They want to put their head in the sand and not deal with it.
Right. And I lectured at Chautauqua this year, Brian, and that's the heart of American liberalism, Western New York. But it's very prestigious, by the way, to lecture at Chautauqua. I think I'm the only person invited through the pandemic on a pandemic issue.
And you got a lot of uninvites during the pandemic, I'll tell you that.
Right. But, and formerly, Teddy Roosevelt has lectured at Chautauqua. I mean, the presidents of the United States have lectured there. So anyhow, I lectured at Chautauqua, and I was just trying to tell people that, listen, this has happened before. People wonder, why is medicine off kilter right now? I said, it's happened before. And I gave 2 solid examples. One is the first great cocaine epidemic from 1860 to about 1920. Every drug company that made a product, it was a derivative of cocaine. Merck, Pfizer, Warner Lambert, you name it, it was a cocaine derivative. And cocaine became a part of anesthesia. The father, Halsted, the father of modern surgery at Hopkins, he became a cocaine addict. Sigmund Freud became a cocaine addict. It was in Coca-Cola, it was in red wine. And finally, the doctors, by the way, expressed no concerns over the addictive properties of cocaine. And in JAMA, the major journal at the time, over 60 years, there was 1 paper published of concern on cocaine addiction. 1 in 60 years. And finally, wow. Woodrow Wilson had to just pull it off the market. And the same thing happened in the UK. The UK Dangerous Narcotic Act was passed around 19. So on cocaine, the irrational exuberance over cocaine, the drug companies didn't stop, the doctors didn't stop. It's the same as messenger RNA. I'll give you another example. This is more recent. That's smoking. 1920 to 1978. We got to about 1940, 1950. Every doctor smoked. Every nurse smoked. Doctors had smoking campaigns in their office. American Tobacco Company, R.G.R. Reynolds, Philip Morris, they had physician marketing campaigns where doctors handed out cigarettes to their patients. So then Austin Bradford Hill and Richard Dahl in the UK published the first analysis. They presented to Medical Research Council in 1950. Smoking looks like it causes lung cancer. They're criticized. They're rejected. They're dismissed. And so they carry out the physician smoking study for the next 3 years, come back with convincing evidence. Half the doctors are dying due to smoking. Even then, they're ignored. Surgeon General Luther Terry, 1964, has to call all the smoking doctors, chiefs of medicine in the country, to Washington and said smoking causes lung cancer. They still ignore him. And it wasn't until 1978 before the American Medical Association has its first pamphlet to the public about the harms of smoking. 1978. I mean, I was a teenager by that time. Can you imagine this, Brian? This is astonishing.
Well, we had the same thing. Yeah, we had the same thing with the long-acting opiates. OxyContin's not addictive, and like we've done it over and over. You look at, as a matter of fact, I was in Kentucky visiting family, and they were saying, all the distilleries said, yeah, we would have went bankrupt, but the doctors wrote prescriptions to say that people need their bourbon, right? So that's what kept them afloat. They wrote thousands of prescriptions per doctor for the people.
Here's the so doctors are absolutely on the wrong side of messenger RNA and spike protein. Listen, I've given grand rounds at virtually every major medical center in the United States, including Harvard and the Mayo Clinic. They all know me. That one of my patients went there recently and said, listen, I'm following Dr. McCullough. He's publishing this. And the doctors at Mayo Clinic said, we know Dr. McCullough. We know about his research, and we don't recognize it. So they are willfully blind at the Mayo Clinic. And just like Luther Terry was kind of blown off as the Surgeon General, you and I, in a sense, are kind of being blown off. Now, who's listening to us are the public, for sure. A few, dignitaries in the Senate, a few people worldwide, a few podcasters like Joe Rogan and others. And we're in this very, very unusual time. And misleading papers continue to be published. There's one today out in JAMA about, COVID vaccination in Canada in pregnant women looks like it was beneficial. Well, what's the problem there? There's no control over who had the infection previously, who didn't, who got early treatment, who didn't. There was no randomization, no blindedness. You can't make an efficacy claim from flawed data. You're very, very unlikely going to be cherry picking. And I guarantee a similar analysis that found the COVID vaccine was related to harm was not published in JAMA. So we don't have a balance from the non-randomized data. So
yeah, we're seeing attacks on people who are publishing, seeing upticks in cancer. Those studies are getting cyber attacked and taken down.
Yes.
And Sabine Hazen, what she went through when she said, look, it's affecting the gut microbiome in a bad way. So all this real science stuff that instead of suppressing, we have to look at it and go, okay, let's weigh this. Is this true or not true? That's why I wanted to talk to you and go, okay, if someone's at 3,000, should we do something about it? Should we not worry about it? And then
I would. If there's symptoms, I did it myself. Yeah. Now, I don't have too much worry about people at 2,000 or 3,000. I haven't seen any spontaneous DVTs or cardiac arrest or anything serious. Now, I do check a few other blood tests. I do want to know if the spike protein has triggered autoimmunity. It's very important. And so I check the ANA, the anti-nuclear antibody, rheumatoid factor, and the anti-citrulated peptide. And if there's a signal for autoimmunity, I at least park that in the equation. If it's really high and a dangerous pattern, I'll use hydroxychloroquine, which I found to be very effective in a sense, shutting off that autoimmunity. And autoimmunity, by the way, can occur after the infection or after the vaccine. Now, additionally, I do check an index of, and it can be used this way, of microclotting or even macroclotting, and that's the D-dimer. You mentioned it. And the assay I use has a normal range of 0 to 0.5. But what I found is that there is a intermediate threshold of 0.2. So 0 to 0.2, I can tell you, I think patients are free and clear. 0.2 to 0.5, I worry about them. Many times suggest low-dose aspirin. They clearly should be on spike detox. Over 0.5, watch out. There's probably blood clotting somewhere. Every so often, in a syndrome like you mentioned, where there's evidence of microvascular thrombosis, I'll use an anticoagulant like apixaban, or rivaroxaban, or dabigatran. And then clearly in these syndromes, and you'll see them occasionally where it's just vicious thrombosis, check the lupus anticoagulant and the anticardiolipin antibody. When that's positive, and I have several of those patients in my practice, the only thing that works is warfarin. So we actually have to use warfarin. The novel anticoagulants, in my experience and in clinical literature, don't work.
Wow.
And then I have to tell you, I think the rest of the decision making here is what's called syndromic. Syndromic. And what I mean by that is if there's a syndrome of recurrent SARS-CoV-2 infection or suspected infection, and there's any craniofacial syndrome, hearing loss, unilateral hearing loss, headaches, trigeminal neuralgia, skin rashes, persistent pulmonary symptoms or findings, night sweats. That's a very important trigger. Sweating at night, unusual heavy sweating at night. There could be what's called a SARS-CoV-2 reservoir, meaning the virus is still in them and alive, replicating. There was a paper from the pediatric literature where this virus was found alive in the GI tract about 5 months later in kids who are doing poorly. And then the Chertow paper from the National Institutes of Health that found the virus alive and replicating a year after people had serious COVID in 2020, a year. So, and these were people who ultimately died and had autopsies. So the point is, I'm not afraid to put people on ivermectin who fit that syndrome. And when I do it, it's full dose ivermectin. So somebody your size, Brian, would probably be 48 milligrams, I'm guessing. For me, it'd probably be, let's say, 36. And I do it for 90 days. And so, I've all of these approaches I've published. I stand behind them. We're publishing case reports the best we can. We're working with some biotech labs. We're working with the German lab. I mean, I'm doing everything I can as a single physician. And I faced tremendous headwinds professionally, having to move from office to office.
Sure.
Yeah.
Yeah.
So we're in a time of great controversy, but I think you and I are aligned. We're not off track here. I've cited many papers during this interview, and I do it when I testify in the U.S. Senate. No one on the other side shows up.
Never. I've never heard Fauci quote a paper ever.
But not
ever.
But no one from the Mayo Clinic will show up and tell us, wow, this is how they handled the vaccine and the spike protein. They won't show up. And by the way, I won't get a bad email. I won't get a bad email from anyone in the major academic colleges. I'm in very high standing in academic medicine in the United States. Nothing. If I got an email from somebody and they said, "Oh, Dr. McCullough, you're a bad person. You're wrong on this," it's just an eerie silence. In fact, I wrote a group at a very prestigious medical center about a case that I became aware of where the spike protein was found in a tumor that was removed from this patient. And I got the paper, I wrote it up, I wrote a cover letter, and I sent it to the entire group of doctors, the surgeons, the medical doctors, the hematologist oncologists, the pulmonologists. No response.
I know it is mind blowing. It really is the amazing non-response, And I have to ask you one more thing in closing because I just saw this yesterday. I was kind of dumbfounded in a way. It sounds like you're becoming more functional medicine, as am I. But you were saying that people with markedly elevated spike proteins also checking for heavy metals. You're seeing a huge uptick of heavy metals, Lyme disease, and these biofilms that can affect health.
It's hard to interpret that because there's a lot of these functional clinics that have a particular focus. And let's say a clinic that has a focus on Lyme disease. If you were to do an audit of their records, virtually every patient would be declared to have positive serologies for Lyme. And if you look at the antibody levels, many times it's a point or two out of the normal range. Mm-hmm. So I've actually never seen a negative serology for Lyme disease, ever. I mean, everybody's uniformly positive. They're uniformly positive for Epstein-Barr virus, although many times the early nuclear antigen, is unimpressive. They're universally positive for cytomegalovirus, universally positive for other tick-borne diseases like babesiosis, for instance, or ehrlichiosis. They are universally positive for heavy metal screening. Palladium, mercury, lead. So the question on the table is, if some normal person living in suburban Dallas-Fort Worth takes a COVID shot and they're just minding their own business, how can they be universally positive for all of these problems? Oh, by the way, another one everyone's positive for, mold.
Mm-hmm. Mold.
What I think is going on is I think there probably is some shift in protein binding, possibly. There clearly is immunosuppression. There's a glycoprotein insert for the spike protein that depresses the immune system. Combined with kind of ultra sensitive, laboratory testing that tends to have a very high positive predictive value, that just everybody is positive.
So you go by clinical symptoms and.
Well, no, I mean, people walk around thinking they have 5 different things. I've had one patient, he's already gone all the way to Switzerland and he's gotten heavy metal and he's on chelation therapy. And also I said, listen, I don't think you have 5 things. It's just, there's something called Occam's razor, meaning, in general, you get a young person, they have one thing. They don't have 5 things. But to conjecture that someone has Lyme, other tick-borne diseases, a whole viral array of things like EBV and CMV, that they have heavy metal toxicity, and they have mold exposure all together. It's too much. And what's happening,
if you treat the spike protein, you see an improvement.
Yeah, you treat the spike protein, and I have to say, I'm being honest, Brian, in the functional medicine world, there's a whole industry built around this.
Absolutely.
It's part of the business model. I mean, if someone goes to a mold clinic, there's a 99% chance they're going to be told they've got a mold problem. And if someone goes to a Lyme clinic, it's the same thing. If they go to a heavy metal clinic. And so there's a gamesmanship here. Now, listen, look at the tests. And if you see an antibody level that's, double, triple, quadruple the upper limit of normal, okay, you probably have something there. But, if
it's minimally elevated.
Yeah, if you see antibody levels and it'll say, 9 to 12 units per ml and somebody is 12.5 or 13, it's just, don't chest. Again, they're uniformly positive. And that's the problem. They're uniformly, and not only that, they typically check 20 or more different tests. Now, remember, when you check 20 tests statistically, one of them is going to be abnormal.
Exactly. Yeah, exactly. But thanks so much, Doc. Thanks for coming on. This is so helpful. And I think obviously the intent is not to scare people and say, hey, if you're having brain fog, you're confused, mom's declining, at least check and see. And then there's stuff we can do at least. It may take a long time, but at least we're doing something to intervene before. It's just like if you find a colon polyp, you take it out. You don't just say, oh, let's just leave it there. So I think, it's just a mindset. So Doc, what's life's best medicine for you? What keeps you going? What got you going through all this COVID thing and going against the wind and storms and all that stuff? Like what makes Peter McCullough?
Yeah, I must be somebody who naturally likes controversy. Prior to this, I was studying heart-kidney interactions, which was controversial. The heart doctor said heart disease has nothing to do with kidney disease and vice versa. It turns out I was right. Now I'm studying this. You and I are studying this great pandemic infection and the vaccines, and we're finding things. And I anticipate, we will be fully vindicated at some point in time. Now, the challenge is to live long enough. Remember I mentioned smoking and Sir Richard Dahl. The tobacco industry tried to destroy him. He was literally wiped off the face of the British medical landscape. And that was around 1954, 55. Now, in 1993, he was knighted as a hero. So you have to live long enough. So you and I have to invest in longevity. We have to live long enough for people to say, you know what, kind of Dr. Lenski, Dr. McCullough, these guys were right on this.
I think we've lived long enough to see a lot of people have changed their tune over the last couple of years, right? It's shocking to me already how many people are saying, uh-oh, how do I get this out of my system? So, I think a lot of people are starting to realize that, when you're in fear, you just don't think rationally and you just do it. You just go, this is the right thing. If I just posted something on the survival rates for COVID, you go, oh my gosh, 99.99993% of kids survived, and healthy people. And you go, gosh, darn it. So, so I'm glad you were there on the front lines. I appreciate you, taking that stand. You didn't have to, and you did. And a lot of these other doctors like Pierre Corey, who proved right with high dose steroids. And, there's one thing after another. People said, listen to us. We're seeing it clinically. So they're like, no, we need randomized controlled trials for 6 years before we'll do, these kind of things. So appreciate you, Doc, and everyone listening. This is gold standard. I hope this helps you and helps you think about your health and what's going on, and don't put your head in the sand. At least look and be kind to yourself, be kind to others, and thank you for your support. And Dr. McCullough, we're waiting for all your. Whenever I see Nick come out with more studies every day, I go, "Oh my gosh, I'm getting a headache." But it's amazing what you guys are doing over there. So thanks for your dedication and hard work.
Let me put in a plug for McCullough Foundation.
Yes.
I'm in the McCullough Foundation studio. Go to www.mcculloughfnd.org. Donate, support us. Nick Kulsher is our epidemiologist. Nick and I trained in public health at University of Michigan. We've trained at the best places in the country. I'm a kind of a top graduate of my medical school, UT Southwestern. I trained in the best medical residency in the country at the time, University of Washington in Seattle. McCullough Foundation is top shelf. We're doing a grant-funded, peer-reviewed, well-recognized research. We're changing public policy. And, of course, the Wellness Company, that's the commercial arm of how we get our therapies out to patients, emergency medical kits, supplements, telemedicine. So go to twc.health/focal points. That'll get you into the Wellness Company system, which is a wonderful alternative. If you can't see Dr. Lenskis and you can't see me and you're out there, what I've tried to tell people is, listen, most of this can be self-managed. You can do this without a doctor, but you need at least the Wellness Company and doctor backup. Check out my podcast, America Out Loud, Talk News, McCullough Report, every Saturday and Sunday. It's on the Apple iHeart Podcast Network. And, of course, our Substack, Focal Points, comes out every day before 5 a.m. Central. That's where you get all the critical updates. It's free, so everybody should sign up for Focal Points. Brian, thank you so much for having me.
Yeah, and I'll grab a link to all that, too, and make sure people can link on it afterwards in the show notes. And, Doc, thanks again. I know you're a busy guy. You're writing papers and saving lives, so I appreciate you taking the time this morning. Blessings to you. Keep up the good fight.
Thank you.
Thank you for listening to this episode. We greatly appreciate your support. We would greatly appreciate a positive thumbs up on all of the platforms like iTunes and Spotify or wherever you're listening. And we just thank you for our Patreon supporters. We greatly appreciate your help in getting this message out. We think there's a lot of important information, and hopefully this helps you. Have a great day, and thank you for listening, and thank you for your support.